We are live.
Good evening. Welcome to our very popular webinar series, Walk-in Patient Series. Today we address a very important problem, sometimes confounding to a comprehensive ophthalmologist, night blindness. How to diagnose, triage, and manage. Chairpersons for today are Dr. Partha Biswas, who is the president of AIOS, and of course, Omar Mehru from Moorfields Eye Hospital, London, joins us as a topic expert. It's a pleasure to introduce Dr. Mehru. He's a consultant ophthalmologist at Moorfields Eye Hospital and St. Thomas Hospital, London, specializing in inherited retinal diseases, which is the topic of today. He's a professor of retinal neuroscience at the University College of London, a visiting professor at King's College Hospital, completed his medical degree and PhD at the University of Cambridge and ophthalmology training in London. He has over 200 publications, several book chapters in prestigious high-impact journals. He has been awarded over 2 million in research funding and has received several awards, including Michael Sanders Award Lecture in 2024. He was elected to the board of the International Society for Clinical Electrophysiology of Vision and the Director of Standards recently in 2025. He is the lead for clinical academic training in Moorfields Biomedical Research Center, runs the very popular annual Moorfields Macula course. The entire course has been put together with efforts by Dr. Simar Ranjan Singh. I thank you, Simar, for this effort. It's a wonderful program that you have put together. Moderators are Simar, and Purna joins him from Narayan Netralaya. Simar is a young professor at Advanced Eye Center, PGI, Chandigarh. Panelists for today are highly accomplished Dr. Muna Bhende from Shankar Netralaya, Chennai, Dr. Parveen Sen from Arvind Agarwal Eye Hospital, Chandigarh, Dr. Vinod Agarwal from RP Center for Ophthalmic Sciences, AIMS, New Delhi, Dr. Shrikant Padi from LV Prasad Eye Institute, Bhubaneswar, and Deepika CP from Narayan Netralaya, Bengaluru. Speakers are young. They're all fellows, I believe. Manu Sharma from PGI, Chandigarh, Dr. Prithvi Naveen from LVPI, Bhubaneswar, Shubhangi Tripathi from Narayan Netralaya, Bengaluru, Priya Prabhu from Shankar Netralaya, Chennai, Smile Singla from RP Center, AIMS, New Delhi, and Shreya Angrish from Narayan Netralaya, Bengaluru. That's the program in brief for today. I request Simar to take over and run the show.
Thank you. Thank you so much, sir, for the kind introduction and this opportunity on behalf of AIOS to get this problem out in a very practical way through cases. But to start off, I think we'll start with Dr. Omar Maru, who is a leading figure in this field, and we'll listen to sir on genetic insights into night vision disorders and how to go about one to see a patient with a night vision disorder. Dr. Omar, please, if you could share your screen.
You can see the slides okay?
Yeah, the slides are visible, Dr. Omar. Please.
Great. Good. Okay, so thanks very much for the invitation again. It's a huge honor and it's great to join you, and I'm looking forward to interesting discussions, hopefully. I'm just going to give a brief talk about genetic insights or genetic causes, really, of night vision problems. It's a huge topic, but I'll cover it, or some of it anyway, quickly, hopefully in the next 10-15 minutes. So clearly, when people have poor night vision, they may complain of problems in dim light levels. It's also worth noting that patients are often unaware of night blindness, and sometimes you need to tease that history out to help inform your diagnosis. So patients, in a lot of Europe and North America and many parts of India, you can live your whole life without really depending on rod vision. So you can easily not notice that your vision in dim light levels is low. So the question we often ask is, okay, your night vision's all right, or it's been all right. If we say 5-10 years ago, you go to the cinema, do you then have any issue finding your seat compared to someone else? And then sometimes the history comes out. Whenever I go to the cinema, I can't find my seat. As I always say, I had a patient tell me I followed the wrong woman in a cinema once, and I had to say, did you do that on purpose or because of your vision? He said, because of my vision. So just check that you can hear me all right, and because there's some work going on here, you can hear my voice, but you can't hear any of the drilling. Is that right?
Could hear some of the delaying also, but
Okay,
it's okay. I mean, you're okay.
you can hear me okay. Great. Good.
So I think, Dr. Priya, if you could mute, your microphone is on.
It's not downloaded.
So
No.
some questions that are important when we're dealing with a patient with night vision problems are, is it one eye or both eyes? When did it start? So with genetic conditions, usually it should be both eyes. It may have started recently, some years ago, or it may be lifelong. The vision problem could be progressive or stationary. All of these things helps us alter our differential diagnosis. And are there any other symptoms like day vision problems, peripheral vision problems? And taking a full medical history, because some of these conditions are syndromic, is also important, as well as a full family history. So I always like to bring it back to the basic physiology as to how does our retina detect light in low light levels, and it's basically the rod photoreceptors and the rod bipolar cells. Obviously, the rest of the visual pathway is important, but when we're talking about IRD causes of night blindness, these are the main cells we're interested in. So our rod photoreceptors detect light. Light is detected by rhodopsin in the outer segments. You have photoisomerization of the visual pigment. You get hyperpolarization of the rod. You get a reduction in glutamate release at the synapse. You get depolarization of rod bipolar cells. And the phototransduction itself also needs to be turned off. And 11-cis retinal has to be recycled, which happens mainly through the retinal pigment epithelium. And the 11-cis retinal, as you know, is derived from vitamin A, which has to be transported to the retina from the blood. So you can have problems in any step in this pathway, sometimes genetic, sometimes non-genetic, which can give rise to night blindness. One of our ways of characterizing patients with night blindness is electrophysiologically, and we look at the dark adapted ERG responses. And in short, anything that's affecting this side of things, phototransduction, transport of 11-cis retinal from the RP to the photoreceptor, or recycling, anything in this side will reduce your DA10A wave. And anything that's after that in the retinal signaling pathway will have a normal A wave, but selective loss of the DA10B wave, giving you an electronegative ERG. So this is just a summary, all there, many, still not exhaustive, genetic causes and non-genetic causes of night blindness, and where each of these causes fits into that pathway that I've just described. And these ones highlighted in yellow are associated with stationary night blindness with a normal looking fundus, including on detailed imaging. But with electrophysiology, we see where the abnormality is. And the ones I've highlighted in green can be relatively stationary, but they have fundus abnormalities, so different from the CSNB with a normal fundus. And then most of the other things are progressive. So we can divide into monogenic and non-monogenic causes. This is just a whole list here. There are possibly many more, but here are quite a few genetic causes. But we shouldn't forget that there are non-genetic causes as well. And just because a patient's in your IRD clinic, it doesn't mean we have many patients referred to IRD clinic and it turns out not to be a genetic condition. It may be vitamin A deficiency, quite rare, in many countries, but prevalent in other countries, or it could be a paraneoplastic retinopathy, or it could be any of these other causes. And we can't think, well, you're in my IRD clinic, you must have a genetic. The patient doesn't read the textbook or know why they've been referred. Just because they've got a bilateral symmetrical problem, it may not always be genetic. Some of these conditions are progressive and others are stationary. So getting that feature in the history is important, and for telling patients about their prognosis. Some of these conditions have abnormal imaging, and you may also get white dots in vitamin A deficiency. Most have a reduced DA10A wave, but there are some of these conditions, as I said before, where the A wave is normal and it's the B wave that's selectively reduced, so you have an electronegative ERG. And one condition has pathognomonic ERGs, which is enhanced S-cone syndrome related to NR2E3 or NRL variants. And vitamin A deficiency, which I'm not going to talk about today, but we've got just highlighting a recent paper. We only published it in the last few weeks, explaining why you get selective rod vision problems in vitamin A deficiency, whereas the cone vision is relatively spared. And we showed that with kind of careful ERGs in different scenarios. So when we go to genetic causes of night blindness, our commonest IRD phenotype is retinitis pigmentosa. And of course, there are many genes that can give you X-linked, autosomal recessive, autosomal dominant, all modes of inheritance of retinitis pigmentosa. And in RP, you always have night blindness preceding the visual field loss, which is then later followed by central vision loss. However, if you have a patient where the night blindness, they have an RP phenotype, but the night blindness was congenital or very early onset, then think in your mind that it could be a gene related to rod phototransduction. So that's an important way of narrowing down the differential diagnosis. So all of RP gives you night blindness, but if the patient's got relatively mild RP, they haven't got much degeneration in the retina, they may be an adult and they've got a preserved macula, but they say their night vision problems were since they were very young, then think it could be a rod phototransduction gene. So we just published this review a few months ago of monogenic retinal diseases associated with phototransduction. And this is the phototransduction pathway that we know and love we draw this after clinic with our fellows every Tuesday evening. And many of these proteins involved in phototransduction, the genes that encode those proteins, variants in them give rise to retinitis pigmentosa, recessive RP. But the clue with these genetic causes is the patient always has night blindness right from the start. There's GNAT1 as well. We've hardly got any of those patients at Moorfields, but GNAT1 is also a phototransduction gene where you can have congenital night blindness, but relatively mild RP otherwise. CNGB1 is an interesting gene because it's expressed in olfactory receptors as well. So some of these patients have problems with their sense of smell that they may not tell you about. They think it's got nothing to do with their vision. So you have to ask them directly, do you have any problems with your sense of smell? And even some other proteins involved in, other genes involved in phototransduction, GCY2D, that encodes guanylyl cyclase, that can be associated with a dominant cone dystrophy. It can also recessively be associated with LCA, but in recent years, there's a syndrome of stationary night blindness associated with some variants in this gene. Yeah, okay, I got muted somehow. So that was published a while ago, but recently, in the last few months, we published a big series of these patients led by Rola Barabad, many of these patients from Moorfields. So my slides, get them moving again. So if night blindness is congenital and the patient's otherwise got relatively mild RP or not too severe RP, think rod phototransduction because it means the rods weren't working before they died. But another gene to think of is this gene TMEM216 that's associated with Joubert syndrome. More recently, a single variant in that gene can give you non-syndromic RP, but many of these patients, for some reason, have congenital night blindness. And we published that last year. And interestingly, 1 in 5 of our African patients seem to have RP associated with variants in this gene. I'll now move on to congenital stationary night blindness, CSNB, where you have a normal fundus. Electrophysiologically, this is classified into Riggs type, where the A wave is reduced. That's quite rare. And Schubert-Bornschein type, where you have a normal-sized A wave, but an electronegative ERG. And Yozo Miyake many years ago divided this into complete and incomplete CSNB. They have different genetic causes and they have different ERG phenotypes. For complete CSNB, you've just got loss of the on-bipolar cells only, on-bipolar cell signals, whereas incomplete, you lose on and off signals. And each of these are associated with just a handful of genes. These are the ERGs you'd get in complete and incomplete CSNB. There's a healthy control on the left, complete and incomplete here, and excellent retinal retinoschisis also shown there, gives you an electronegative ERG. But there are various features in the ERGs that tell you this patient has complete or incomplete CSNB. They've both got electronegative DA10 ERGs, but you see the differences in other stimuli. Especially this particular shape is very characteristic of selective loss of the on-bipolar pathway. When you see this shape in the LA3 ERG, a broad A wave, sharply rising attenuated B wave, preservation of the I wave, that means there's selective loss of on-bipolar cell signals. It tells you the patient's either got complete CSNB, or if the night blindness is recent, they've got MAR. Quite possibly they've got melanoma-associated retinopathy. Even if they don't know that they've got a melanoma, it strongly suggests melanoma-associated retinopathy. So get to recognize this shape. I say people should learn this shape in nursery or kindergarten because it's so highly specific for selective loss of the on pathway. Another ERG protocol that's helpful is the on-off ERG, where you give a long stimulus. This is a healthy control here. We recorded this with a portable device, and this is a patient with complete CSNB where all they're losing is the B wave in response to stimulus onset, but the D wave in response to stimulus offset is intact. Then you can have congenital stationary night blindness with an abnormal fundus, I won't go through this in detail because of time, but they can have stationary night blindness, but abnormalities in the fundus. In Oguchi disease, you get this shiny looking fundus. In fundus albipunctatus, you get lots of white dots. And in enhanced S-cone syndrome, you have pathognomonic ERGs, but often you have nummular areas of pigmentation and a certain pattern, temporal kind of crescent of autofluorescence abnormality. Those genes can also be associated with progressive degeneration. So this is the kind of sheen, golden sheen you get with Oguchi disease. Now we'll go on to some cases very quickly. I think I've got a minute or two left. We've got a high myope who had night vision problems since a young age, 18-year-old. You look at that family history. This is the patient affected. There are other males affected, connected through unaffected females. This tells you this must be X-linked. Visual acuity was subnormal. Imaging was pretty normal apart from just high myopia. So changes associated with high myopia, a bit of a dome-shaped macula, but otherwise nothing very specific. He got recruited for whole genome sequencing, and they didn't find any cause. So this just shows you can do the whole genome and still they'll miss the cause. However, his ERGs were so specific. When we go back to his ERGs that were done aged 5, he had some features that were unmistakably associated with incomplete CSNB. And that's what Tony Robson, our ERG specialist, had suggested. When you look at the causes of incomplete CSNB, there's only one X-linked gene. So he had to have a mutation in CACNA1F. And we reinterrogated his data and we found that they'd missed a frame-shifting mutation in CACNA1F. Here's another case, quick case, 22-year-old female, high myopia, poor night vision since childhood. She has to leave in 30 minutes. She didn't get the memo that in my clinic you have to stay for hours because you get your vision done, you get your imaging, you see the fellow, then you see me, but she's got to leave in 30 minutes. So what do we do? One test can we do to get the diagnosis within a few minutes? Answer is we could easily rebook her. There's nothing urgent about this case, but that would ruin the story. So a handheld ERG, because this suggests complete CSNB as a possibility, a handheld ERG was done in 5 minutes in clinic, and you can see that shape I was telling you about, where you have this characteristic broadened A wave trough, sharply rising B wave, and I wave preservation, and then the on-off ERG showed selective loss of the response B wave. This patient has to have complete CSNB. That narrows it down to just a handful of genes. There's a new gene about to be published called eggflam that encodes a protein called picaturin. I'm not joking, it's really called picaturin. That's another cause of complete CSNB. But already in 5 minutes, we've narrowed this patient's disease down to just a few genes. It won't be NYX because that's X-linked and she's female. And when we got the result, she did have mutations, we got the result a year later after 5 minutes of ERGs, and she had mutations in TRPM1. Final case, I've put this backwards because I got this backwards. This is what's happening in modern days. We don't see the patient. Someone just emails me and says, what do you think of this genetic result? So I got an email saying, oh, this patient was homozygous for a variant of uncertain significance in CNGB1. What do you think? I've not even seen the patient or the imaging. What am I meant to think? So when we're faced with variants of uncertain significance, we have to think, does it fit the phenotype? I'm going to go quickly because I've run out of time. Basically, I responded and said, if it is CNGB1, they should have RP, but they should have lifelong night blindness. They might have a problem with their sense of smell. And that could give us a clue as to know whether this really is the cause. Cut a long story short, that was the case. He had RP and he had a lifelong problem with his night vision, and he had problems with his sense of smell that we asked him directly about. So we were sure that the gene was CNGB1. So the take-home message there is that now these days I'm seeing patients with their genetic result already, and I've got to decide, is that genetic result the right result or just a red herring? And we have to really fit to the phenotype. So that's my summary slide again. The first patient I showed you, the case had a problem there. Second patient had a problem there. Third patient had a problem there. And any other place there can be a problem, but it helps us classify the different causes, genetic and non-genetic, of night blindness. So in conclusion, it's always helpful to take a full history. Electrophysiology, especially when imaging is non-specific, can narrow the differential diagnosis, and there could be a genetic cause, but you should keep these other things in mind, other possible investigations that may be needed. And that's it. Thank you very much, and sorry I went a bit over time.
Thank you, Dr. Omar. That was just excellent. The perspective that you gave us of narrowing down to the genes from the phenotype, that was excellent. Poorna, you want to join in, please?
Thank you, Professor Omar, for the wonderful presentation as usual. So, I mean, I have a few basic questions, So how often you find this VUS in the context of CSNBs? So not in the context of RP or orphan dystrophy-related night blindness.
Yeah, so in CSNB, we sometimes get variants of uncertain significance, and we've noticed we get that more commonly. We have all ethnicities in London, but in our African patients where there's less reference data, we often get variants of uncertain significance, so it does happen. But one thing that can help us is that CSNB has such a, like complete and incomplete, have such a almost pathognomonic electrophysiological phenotype. Then if they have a rare variant in one of those few genes, we can upgrade that variant of uncertain significance to likely pathogenic. With RP, where it's not so specific, it's less easy to upgrade something. But if someone has some congenital night blindness and they find a rare variant in a phototransduction gene, then that in my mind is enough to maybe upgrade that variant.
I just ask question out of my perspective, for my understanding. And my follow-up question is, often what I get, queries from a lot of people in the Indian context, that the handled ERG. So how often you use that handled ERG, either as a tool to document, diagnose, or screen? So could you please brief on the same?
Yeah. So are you asking me or?
Yes, I'm asking you. Yeah, handled
yes.
ERG.
Yeah, so the handheld ERG, I think it's a very handy device. So at Moorfields, we're kind of spoiled. We've got a very good electrophysiology department, 10 testing labs. So we get state-of-the-art electrophysiology. There's still several months wait, I have to say. But if they need anything urgently, we can do it. So I think conventional ERGs with conventional equipment, with full dark adaptation, there's no replacement for that. But you can do many of those things with full field ERGs with a handheld. But where I find it particularly useful in my own practice is when there's something about the photopic ERG, because then you can do it in 5 minutes. If I've got to do a dark adapted ERG, then the patient still has to dark adapt for 20 minutes supervised, and then you do the hand, and then you may as well just get a normal ERG. But there are a few, for example, the case I showed, complete CSNB, the LA3 is so stereotyped that I'll just find that out, 5 minutes with a handheld ERG. If I'm suspecting enhanced S-cone syndrome, it has an S-cone protocol, and if they've got a huge S-cone response, nothing else gives you that, so you've already got it down to NR2E3 or NRL. So there are selected cases where I use it, and even for prognosticating with Stargardt's, what's going to tell you what electrophysiology group they're in is their full field cone ERG affected. And again, that you could potentially tell within 5 minutes. So I think selected cases where the photopic ERG could give you something very helpful, then I do it. Otherwise, I might get full gold standard ERGs.
It has to be used by an expert who is very good at the regular standard ERGs. Fine. So I think Dr. Munna ma'am and Dr. Vinod wanted to comment.
Dr. Vinod, please.
Hi, Dr. Omar, excellent as always. When we hear you, it feels that we don't know anything, about electrophysiology. Again, great. So I'll come back to the question of VOUS. So we understand that we do get many of them. So now, for example, I have a person where the phenotype fits in with VOUS. So what do we do further?
Yeah, so
Clinician.
yeah, I mean it's a really important question, and I'm sure you'll have good thoughts as well. I mean, we usually do look at it on a case by case basis. So as I've said, if the if something about the phenotype, whether it's electrophysiology or something about the retinal appearance, is really specific. For example, we had a patient with Oguchi disease recently who had a shiny fundus, everything ERGs, everything consistent, and she was homozygous for a very rare variant in GRK1. And the other gene for Oguchi disease, SAG, she had no rare variant. So we were pretty sure, that's the cause. So when it's something very specific, then you can be quite sure. If it's not so specific, you look for how rare is it. So we look at for example, the NOMAD database, genomes aggregation database. We look in that to see how rare the variant is. If it's very rare, then it could be an IRD associated gene. If you can do segregation, that would help. Let's say it's a dominant condition you're dealing with. You could go a few generations up, and that same variant is constantly found. That might help you. If you have some other families where that variant's found, or you can look on databases like ClinVar, Franklin. It's quite good to see whether other people have published or reported that variant in the context of the same disease. So these are some of the things we do. Sometimes we still, because they have these ACMG guidelines and they're very strict, even if we say we think this is it, sometimes they still won't accept. The geneticists say, well, we won't issue a definitive report, say, fine, maybe we need more evidence. At the moment, perhaps it doesn't make much of a difference. It's going to make more of a difference when it's going to be critical. Like, for example, RP65, we have a treatment, you get a VUS. That's serious, because if we're wrong, then we're going to give someone a potentially blinding treatment, detach their retina for no good reason, or if we miss it, then we're going to deny them an important treatment. So in those cases like RP65, where you have signs where the autofluorescence is very low, lifelong night blindness, poor vision from very early on, no other LCA genes found, that would make us maybe upgrade a VUS in RP65. And we often have multidisciplinary team meetings where we discuss these cases, because no one wants to take the decision themselves that I'm going to treat this patient. So we have like a national ophthalmic genomics meeting every 3 months in the UK where people present such cases. And then when we have consensus, yes, we think you should treat, then it kind of distributes the responsibility a bit. And then, people feel a bit more comfortable about going ahead.
The second question is very related to it. So sometimes you have a very typical phenotype. For example, just little of this context, a patient with, say, a Stargardt's phenotype, where you have flex, where you have Stargardt's with the flavimaculatus. You are very sure that it cannot be anything else. And then a genetic mutation comes in ABCA4, which is heterozygous. Now, how do we go about this particular scenario?
Yeah, great question. We are faced with that quite a lot. So I think it depends how you've done your sequencing for a start. So in the UK now, they do, in many settings, they do lots of genes at once. So there are some other genetic causes that can look like ABCA4, like PRPH2, LOVL4, though we've got none of those in the UK. They seem to have lots in America. Some of the other genes as well. So if you didn't find any findings, any variants in those genes, then that would maybe add some weight. Similarly, if there are deep intronic variants in ABCA4, so you might want to talk to your lab. Would you have found these? Because some labs, they just do the exome and they miss out these well-known deep intronic variants in ABCA4. But I think there are some cases where we think it's very likely ABCA4. As you say, the phenotype fits. One variant found, which is known pathogenic. So that's quite good evidence to start with, and maybe something else got missed. Also being aware of there are certain variants that are kind of hypomorphic. They're quite prevalent and not all labs declare them. So for example, in white European patients, 5% or more have this 1868 codon variant in ABCA4. That on its own isn't pathogenic, but if it's in trans with a very severe variant, then those patients can get disease. So our labs in the past weren't reporting that. They thought that was too common. And I'm sure in other populations you'll have something similar. In a lot of our African patients, there's a 2107 variant that seems to be a bit similar. So that could be another thing that was missed in your patients. So these are the things. But I totally agree. Sometimes you can't go any further and you just have to wait for someone to publish another variant and then you might find your patient's got it.
Dr. Kumar, just following up on that, I wanted to ask how important is to once we get the reports, how important is it to kind of report it to like ClinVar or one of the databases, or is it okay to just publish it and then that will also have the same impact on that gene being upgraded from a VUS to maybe a lightly pathogenic or a pathogenic one?
Yeah, I think absolutely. When you have a variant and you're convinced of it, it is worth reporting it, and it could be in the form of a publication, which often is very good because then everyone can look at the full data for that patient. But even if one didn't uploaded it to ClinVar or Franklin, these repositories of mutation, I think is very helpful. I have to say we're probably guilty of not always uploading a variant that we're convinced of, though we try our best to kind of publish and collate our variants so that people can be aware of them. But I think that is helpful. That's with these rare diseases, that's probably the only way forward, that everyone reports them so that we can benefit from everyone else's experience elsewhere in the world.
Dr. Muna, ma'am, please.
Thank you, Dr. Maru, for a wonderful lecture. My question is on RP65. Sometimes we get a patient who has an RP65 mutation and some other mutation as well. And what do we tell that patient when they say, can I have Luxturna?
Yeah, I think that's difficult as well. So I think if they have a biallelic mutations, both alleles segregated, very sure they have two pathogenic variants on both alleles. And then they have some other mutation, maybe another variant in a recessive gene, but they don't have a biallelic variant. So if you think the other variant is unrelated, maybe it could be modifying, I'm not sure, but probably if you think the RP65 is the cause of their disease and the other variant is incidental, then I think in those patients, they should be considered for Luxturna. If they have another disease that you think is, maybe predominant or very rarely people can have two diseases, then I'm not sure you may counsel them as to, if you're still convinced of the RP65 side of things, you may still be able to do something, but I don't know how well they'll do if they've got another cause of an inherited retinal disease. It's very rare to see that. It's not impossible, but it's very rare that people have two different proper inherited retinal diseases. What's more common is we have either RP65 associated disease and then a rare variant and another recessive gene that's really incidental. That's what we can't find more commonly. But I guess if there are two, definitely reliably definitive IRDs, then it's a bit more challenging. How would that patient do with Luxturna? I'm not sure.
Dr. Maru, if I could ask, we have a lot of general ophthalmologists who are also viewing this and a lot of fellows also. So now that we have a lot of gene therapies in the pipeline, we have one that is approved as well. And you probably have the experience of using it as well in the UK. What kind of workup do you feel is essential for a patient with night blindness who has a RP-like picture, typical RP-like picture? We normally would diagnose that. But what kind of workup is essential if we are thinking of treating these patients in the future to have some basic data on follow-up as to what stage of their disease we might be wanting to treat them? So what kind of workup is basic? So is electrophysiology mandatory if we want to take them up? Or are there some other tests like microperimetry or maybe full fields threshold, subscotopic threshold testing? What is essential in these days?
Yeah, great question. And I think this can vary according to your own setting and what's available and the different costs of different tests. But certainly in London, we try our best to genetically investigate everyone who's suspected of a monogenic disease. So we try to be sure about their genetic diagnosis. In terms of other tests, by default, they all get retinal imaging. So OCT, ultra wide field imaging, we tend to get, and autofluorescence imaging we find very helpful. And that's basically what in our setup, what we get on everyone, that that type of retinal imaging. Do we do visual fields? Logistically, we don't. We've got clinics full of inherited retinal disease patients. The visual field machines are on the glaucoma floor far away. They're already dilated. We just don't get it. But if you had your choice of everything, then I think getting kinetic visual perimetry would be very good, because it would help you follow up these patients and their visual field. I think that would be good, but we don't on most of our patients. Also, electrophysiology, again, I think if you were to get it on everyone, that would be great, but probably we have to choose which patients we need it on. I find anyone where they've got an advanced degeneration and you're going to get undetectable ERGs, ironically, that's what everyone does it in. If someone's got an advanced degeneration, everyone's saying ERG, they need an ERG, and it's undetectable. Why did you do it? Waste of time, waste of the patient's time. But when you do need an ERG, for example, you just see a maculopathy on OCT, but you don't know, is it a macular dystrophy or is there retina-wide cone system dysfunction? Ironically, that's when people don't get ERGs. I ask people, they say, oh, I can see it on the OCT. Yeah, but you can't see what the rest of the cones are doing. So then I would get an ERG when there's either non-specific findings on imaging, or the imaging looks normal, or it's just a maculopathy, or maybe even very mild RP where you'll get a detectable ERG, and maybe that could be a baseline for further assessment later. So I don't get an ERG in every patient, but in some patients, as I've described, we do. Microperimetry, we tend not to. I mean, you're absolutely right. For future trials, it would be great to have that natural history data. It's just something that's not kind of routinely available. Adaptive optics, all of those things are really only available in research settings. So unless we have a particular natural history study for a particular disease, we don't tend to get those investigations done. But I know other centers that perhaps they do that.
What about full
one comment? One comment each from. Yes. After this, I think you can have one comment each from Dr. Deepika and Shrikant. After that, we can go for case discussion. Please go ahead with your question, Simar.
What about full field scotopic threshold testing? Do you use it?
Yeah, absolutely, because that's an outcome measure in many trials. For some of our natural history studies, we are doing it, but we're not doing it routinely for every patient. But it's a very good point, because it's being an outcome measure in so many trials. Maybe you can have an argument, and it's the same equipment as the ERG. If you've got the diagnosis, it does FST. So maybe one could say you should get it on each patient, but we don't as a routine ourselves.
That might be the only measurable thing that we can kind of quantify the difference between two visits.
Yeah, you're absolutely right. Yes, especially when the ERG is undetectable, really a psychophysical test like that may be the only thing you can use. Yes.
Yeah. Deepika, you want to make a point?
Yeah, sure. Thanks. Thank you, Dr. Maruhai. So regarding the talk when you described the cases, like the complete CSNB, the first case, there were some noted systemic feature as well. I'm not remembering whether it is something I don't know whether there was any association with the TRPM1 gene, the systemic.
So there was the first case was incomplete CSNB.
Incomplete CSNB. Okay. Yeah.
I think, and oh yeah, you're right. In their history, thanks for remembering. They had dyspraxia and dyslexia. I think that wasn't really related.
Okay.
There probably is a little bit of a higher incidence of that in people with vision problems, but I think it probably wasn't related in this case.
Okay. Yeah. Thank you, Shrikant. Anything?
Yeah. Hi, Omar. Great talk. It was a great discussion. So I just wanted to extend the discussion to the family screening. So how you go about parental screening or sibling screening? So what test do you perform? Electrophysiological test along with the genetic testing? How you go about the family screening?
Yeah, great question. So I have to say I see adults rather than children, but I know my colleagues who see children often will send the genetic test as a trio from the patient and their parents, because their parents are often with them, and then you can very easily work out the phase of different variants and maternal paternal inheritance, so that can be helpful. Otherwise, we tend to go on a case-by-case basis. So if we're unsure and a parent happens to be with them, we may do some imaging in clinic. Like, it's very easy to get, say, an undilated autofluorescence or an OCT. So for example, if I'm seeing, especially with the X-linked case, I might be seeing a male and I'm suspecting X-linked RP or X-linked ocular albinism or something like that, then imaging the mum could be really helpful in those situations. So it's kind of case by case. You have to obviously warn the parent, maybe they're not expecting that they're going to be examined, that you may find something, but if they're happy, then we can image them as well. Again, if we're wondering about Stargardt's, but then the parent has flex as well, then we may push us towards PRPH2. So we don't do it with every patient, but where we think it would be helpful, we often do imaging of a relative in clinic. And then also when we get a genetic, if we haven't sent the parental DNA already, when we get a genetic result, maybe we'll take from the parents or the children to try and segregate those alleles or confirm, in which case it'll just be looking for those particular changes we already found in the proband.
Last
Just logged in. I think
comment
if
from
we can,
Dr. Purveet Singh, ma'am, and then Manu, you can be ready with your case, please.
Yeah, thank you, Simar, and thank you, Dr. Omar, for a wonderful talk. There's one question that I've always had whenever I'm dealing with night blindness patients is how do you characterize or how do you suspect that you are dealing with a RIGS type of CSNB? And do you still try to make a distinction or is it now more genetically classified?
I think these days we have moved to genetics a lot, but I think if we're thinking of CSNB, that's one of the situations where electrophysiology is very helpful. True RIG CSNB is quite rare, and it seems to be when you have those dominant mutations in phototransduction genes that just activate the pathway, so the rods are unresponsive. You can get things that look a bit like that in some rhodopsin mutations. You can also get it with vitamin A deficiency. It can look like RIG CSNB. You can get it with SLC24A1, this cause of mild RP. But otherwise, it's not so common, but it might guide you as to what genes you might look at. But the Schubert-Bornschein CSNB, where they have a normal A wave and a reduced B wave, that is quite specific, and you can usually divide that into complete or incomplete based on the other ERGs, and then really restrict the genes that you're interested in.
So the extended protocols come in only when you suspect on the full field ARG, or do you do some of them as an integral part of your electrophysiology?
So the way our electrophysiology department works is they do the standard international standard, and then they'll also tend to do a dim flash red ERG. It just happens to be, they're very happy to do that, and they'll do on-off ERGs on any patient where they think it might be helpful. So the technicians are quite well trained. So if they think, oh, this patient might have, has an electronegative ERG, then they'll immediately, after the standard ERGs, go on to do an on-off to characterize that further. If there's any possibility of enhanced S-cone, they might do an S-cone ERG as well. I can't remember, maybe at the moment they're doing S-cones and on-offs on everyone just in case they need it, but it might be done. You could do it judiciously on a case-by-case basis, I think.
Thank you. Thank you for a nice talk, and thank you for the answers. We've clarified a lot of our doubts. Thank you.
Thanks.
Dr. Omar. Move on through some interesting cases now. Our first presenter is Dr. Manu Sharma. She is a MCH Vitreoretinal Surgery Fellow with us at the Advanced Eye Center, PGI Chandigarh, and she's just about submitted her thesis on rod cone dystrophies, genetic and genotype-phenotype correlations, and she's going to present a case of CERKL mutation-associated rod cone dystrophy, which is amongst the commonest that we find here in this part of the country in India. Dr. Manu, if you can share your screen, please. So you are muted, Manu. If you can unmute your mic also.
So my screen is visible?
Yeah, I need to go on full screen.
Yes, sir.
Just go on slideshow mode.
Yes, sir. Thank you for the introduction, sir. Good evening, everyone. Thank you, AIOS, for this opportunity.
Yeah, one side of the screen is kind of
Dr.
blocked.
Manu, can I interrupt, please?
Yes, sir.
Can you just stop share for a minute?
Stop sharing?
Yes, please.
1 second, sir. I couldn't.
I've stopped it. Just click on the share screen once. Don't go sharing. Just click on the share screen once. right hand side, you will have an option called optimize for video sharing. Just ensure you've unchecked it.
Okay. Yes, sir. Optimize
uncheck
for
that.
video sharing.
Just uncheck that
Okay.
and then share.
Now is it okay?
Perfect. You can go.
No, it's okay, sir.
Yeah. Go ahead, Manu.
Okay. So my topic is CRKL mutation associated Rodcon dystrophies. I can't move my slide.
Just click once on
Just click on the screen.
screen.
Okay. Okay. So CRKL gene encodes for ceramide kinase-like protein, which is a homologue of ceramide kinase, which helps in conversion of ceramide to ceramide burn phosphate, which is the constituent of cell membranes and participate in intracellular signaling and apoptosis, and it protects the photoreceptors from oxidative stress. So when it is absent, it leads to photoreceptors more prone to apoptosis and severe Rodcon degeneration. So here's a 34 years old female, which is a typical case of CRKL. She presented with history of night blindness since childhood. There was no family history. She presented with a visual acuity of counting finger 2 meter in both eyes. Her best corrected visual acuity was -4 diopter sphere. It was 660. So here in the ultra-wide field photograph, we can see there is a severe arteriolar attenuation with mild disc pallor. There are prominent bony spicules nasally in both eyes. Even present temporally, they are more nasally, and some scalloped areas of chorioretinal degeneration can be seen temporally. In the macular area, there is some areas of hypo and hyperpigmentation. On fundus autofluorescence, this is a typical the CRKL feature look like. There are multiple areas of hypo and hyperpigmentation with early macular involvement with peripapillary areas of atrophy, and these are in the temporally we can see the scalloped areas of hyperpigmentation, the hyper autofluorescence and hypoautofluorescence. So these scalloped area temporally which is present there are typical of seen in CRKL associated Rodcon dystrophy. And this is our OCT scan passing through the center of the macula. We can see there is the loss of outer retinal layers with some hyperreflective foci are seen in the photoreceptor layers where the degeneration of the photoreceptors. And some choroidal caverns can be seen with mild thickening of the choroid. This is the ERG of the patient, which shows the dark adapted response is decreased, and as well as the con response, the light adapted response is also extinguished in the both eyes. We went ahead with the whole exome sequencing, and it came out to be CRKL positive, gene present on exon 7. The most common variant we found in our study also, this 967_968 deletion, which is homozygous autosomal recessive, responsible for retinitis pigmentosa 26, and it was pathogenic according to ACMG criteria. This is the 3-year data in our study we recently did in my thesis. We did the ultra wide field fundus fluorescent angiography characteristics in Rodcon dystrophies. In our ambidextrous data, we found 370 patients of Rodcon dystrophy. 277 undergo genetic screening. Out of those 277, 40 patients had CRKL gene positive, and 30 patients, the ultra-wide field imaging was available, and we did phenotype-genotype correlation. The mean age was 30 years, and male to female ratio was 20:10. The most common variant we found in our study in 19 patients, and it was pathogenic, homozygous autosomal recessive, the 967_968 deletion. And the other common variant which was found in 6 patients was 1045_1046 deletion in exon 8, homozygous autosomal recessive and pathogenic according to the ACMG criteria. And one novel mutation we found, which was likely compound heterozygous, found in 2 patients with one variant as C910 deletion, which was pathogenic, and other was the variant of uncertain significance. This novel variant was present, C.316, C replaced by T. These are some of the images from our data, but we found this C967_968 deletion gene is most commonly associated with this presentation of diffuse loss with peri-arteriolar sparing of RPE pattern, which is also described in one of the article by Dr. Omar Mehru. And it was seen more commonly in the young patients. Our 8 patients had this type of presentation. And in the middle age group, we found more of the scallop pattern of chorioretinal dystrophy temporally. And the pattern which is shown in the middle age group, both of the deletions we found commonly in the middle age group, some granular pattern in the periphery, and all of the patients have early macular involvement. With the advancing age, there is more of the scallop pattern we seen in the periphery. And this is the pattern, the first pattern with the advancing age. When the disease become more advanced, there is the total loss of the RPE and more of the scallop pattern, more of the nummular pattern is seen in the periphery along with the more central involvement. And some of the more patterns we see in the middle age group where there is only this one sectoral involvement and only the peripheral involvement. And the one patient with the 968 deletion and 2 with the other 1045_1046 deletion, we found this Robson-Holder ring type of pattern, which is not seen in other patients. Is an uncommon presentation we had. And the other had this last pattern, the figure H, where we found the peripapillary hyperautofluorescence with peripheral granular pattern. So there are the 2 studies, one the international and the one the Indian study, where the patterns we have described, they are corroborating with these studies also. The first one is the multicentric study by Sir only, the early onset and the macular involvement, early macular involvement also seen in their study. And the Indian study, the 40 patient data, the most common variant they have seen is C1045_1046 deletion, which is also seen in 6 of our patients. So to conclude, early center involvement is the rule. Young age granular pattern is most commonly seen with periarteriolar RP sparing, but they had good vision. With advancing age, there is a poor vision along with the more of a nummular pattern or scalloped road con dystrophy, scalloped RPE degenerative changes in the periphery. So same gene, same variant may have buried phenotypes at the different age groups. Thank you.
Thank you, Manu. I think excellent presentation. Dr. Omar, if you could have your thoughts on the phenotype correlations in CRKL associated dystrophies. As she showed, the pattern, the variant that is most common with us is actually less found in the rest of the studies, and that is very predominant in our study from Northern India. So if you could have your thoughts on the genotype-phenotype correlations for this.
Yeah, thanks. Great presentation, and yeah, it's a very interesting genetic cause, and I didn't realize it was so prevalent there. We often find that with CRKL, it's the common history. It's kind of university age patients start losing vision, and it progresses quite quickly. That's our experience. So compared to most other IRDs that progress quite slowly, unfortunately, this takes away a lot of the vision relatively quickly compared to other inherited retinal diseases, though there is some variability. I mean, it's a loss of function phenotype, but we often find that if a patient has at least one missense variant, as opposed to 2 biallelic, stop variants, often in many conditions, and I can't really remember whether we found this for CRKL or not. Often, if you have at least one missense variant rather than double nulls, you tend to be more mildly affected. But that, exactly as you showed, this kind of mottled early macular involvement seems to be something we see in our patients. It was interesting you had that hyperautofluorescent ring. Often we tend not to see that. We see that more in RP, although in your patient, I think the ring, within the ring, it was all very atrophic. Outside the ring, it was normal. And then outside, in the far periphery, it became abnormal again. So it's almost a reverse Robson ring, which I've started calling a Nosbor ring, because that's Robson backwards, when you have the inside abnormal and the outside normal. I should check with Tony. That was happy for me to call it that. But it's really interesting. And the variability, it's so important to define that, because sometimes it could be genotype related, or there could be so many modifiers. As you showed, patients with the same genotype can have different phenotypes. presumably because there are other genetic factors or environmental factors that are important. And that's the next, I think, big frontier in IRDs, is discovering these modifiers. Because if we can work out why, the same variant can be severe in one person, mild in another, maybe we can make the severe person mild. So I think these studies are really important. Thanks.
Right. And yes, that has been our experience. Like most of these patients are actually college going or just starting off their, many of them doctors done their MBBS and then suddenly detected rather than very early presentation. But yes, the early macular involvement kind of takes away the vision very fast. Uh, Dr. Parveen Sain, ma'am, your thoughts, please.
Yeah, thanks, Simar. So this is something which we had published long time ago, and though I published it while I was in South, interestingly, most of the population that we found this mutation in was North Indian. So I think this is particularly prevalent in the North India rather than the South Indian population. So we could probably look into what are the factors and how it is populating in the whole population, maybe some as they say a larger consanguinity, or a small group which is the Agrawal group or something which is commonly known where it is particularly seen. One particular autofluorescence pattern I was very interested in, where you showed that whether it is a typical phenotype of a variant, or is it that the disease is progressing. That is why you see the Robson ring there, and you don't see the Robson ring in the first type of autofluorescence pattern that you showed. So, if you go back to that slide, that is something which I'm in when you see a perirrobson, the Robson ring, that time maybe the disease is still progressing, while in the first one it is. So I'm not sure whether it is maybe Dr. Omar's opinion on this, whether it's really
So
a
just that,
phenotypic thing. Yeah, this one. So if you see the first, the figure E, you don't see the ring. But if you see the figure G, you see the ring. And you
Yes,
see
ma'am.
this ring not only in the center, but also in the periphery, where, as Dr. Omar just mentioned, that the central area
Yes,
is
ma'am.
involved, and then the margin of the center and the mid peripheral, there is a ring, and then again in the periphery, that ring starts, because here this I have seen this pattern also. Here it starts moving towards the center then. So whether the G shows that this variant may be similar to E, but the E is more advanced and G is in evolution, and the G may actually result in a pattern like E over a period of time. So the effect of age, I think, is also extremely important when we
Yes,
look
ma'am.
at those patterns.
The
I think
patients were in younger age group,
Yeah.
middle age group. Yeah,
Mhm.
the G
we
patients
had other
and
younger patients who
E.
did not have the rings, but if you show the previous slide in which you have the younger patients, so not all young patients have the ring typically. So like the figure B is also kind of a young patient. You don't
Yes.
typically have the ring, but yes, the figure A and figure D, the pattern that you see is kind of what we typically associate with when we see this, it's like CRKL on the face of it.
Very interesting. So this is a very, very typical kind of a phenotype, but I made a mistake once recently also. I thought this was CERKL, but then it came out to be PROM1. So PROM1 can also sometimes have a similar kind
Yes.
of phenotype, just to keep it in mind. They will
Yes.
also have these coalescing patterns in the periphery and start with the macular involvement,
I
though I
can say something,
thought,
ma'am.
yeah, please.
I can say something. In my thesis, in other gene mutations, we have found this pattern of, we named it as trizonal pattern. So in other mutations like LCA, RPGR, we have found some trizonal pattern. So center is abnormal, then there is a ring, then there is a sparing of the center retina, then there is a hyperfluorescent ring outside. So some of the trizonal patterns we have seen in our thesis patients. And some patients have these patterns, but they were not willing for genetic screening. So no whole exome sequencing was done for those patients. So we didn't know what the genetics would turn out.
Yeah, can I add something similar here?
Yeah, you can stop screen sharing, Manu. Yeah, please.
Yes, sir. Yes.
So we have come across, like what she told, this reverse Robson holder ring or trizonal ring. Most of them, these type of presentation occur in cone rod type of dystrophy, and CERKL is one type of a mutation where we see predominantly cone involvement, because the CERKL is mostly involved in the cell survival pathway and mitochondrial function also. So cone, as we know, these are highly metabolically active. That's why any mutation, if you see early presentation, especially in younger females, if you see macular atrophy presentation with very less spicules. So CERKL1 is one of the commonest differential diagnosis, along with, you can say, ABCA4 or CRX. That would also come to my radar. So if I kind of do this genotype phenotype correlation. Also, if you see in your cases, you showed these peripheral nummular coin-separated atrophies. So when I see this CERKL along with CRB1 and some cases of early stages of choroideremia, also they present with such kind of presentation. Very interesting case. Thank you.
Purna, your comment, and then you can take up the next case also, please.
Before that, I think maybe the ring what we were discussing, the most of the time CERKL we see is the typical, atrophic patches within the way the expected Robson holder ring should be. It's actually not a ring. In case if I see just a typical Robson holder ring without this atrophic patch, most of the time I'm pretty sure it's not CERKL. Okay, so in fact, in the case what she showed also, at least it had an atrophic patch. I don't know whether, as
Yeah,
Dr. Omar mentioned, call it as river Robson. I was not sure. I was listening to that word for the first time. So that is one thing. And also the first case, the figure E, what we showed, I think along with the CRB, I think Shrikant also mentioned it. I would keep ABCA4 also in mind, especially that flex like I think what you mentioned. So basically, whenever you see a typical RP-like presentation with foveola sparing surrounding atrophic patch and not a Robson ring, most of the time I'm pretty sure that it is CERKL. Yeah. Professor Homer. Meanwhile, I think Dr. Prithvi can start sharing the screen and Omar can complete his comments.
Yeah, and I agree with that exactly as you said, that when you have a typical Robson ring and inside it's healthy and it's a typical RP picture, that's very unlikely to be CERKL. But when it's either you don't have a Robson ring and this widespread mottling with early macular involvement, or as you showed, a kind of ring but atrophy inside, then we do think CERKL. And I think Dr. Praveen was right that the PROM1 also comes to mind, dominant PROM1, which can have a ring and then atrophy in the center, but can also have peripheral involvement, and then recessive PROM1, which is, very widespread and can look like that.
Thank you so much, Professor Amaru. I think now I'll invite Dr. Prithvi Mohan. She's a fellow in LV Prasad Eye Institute, Bhubaneswar. Over to you, Dr. Prithvi. Prithvi, just unmute yourself. I can't hear you.
Yeah, am I audible?
Yes, you're audible, and it's in full screen mode. All good.
Right. Very good evening. Thank you for the introduction. I'm Prithvi Naveen, long-term retina fellow at Anand Bajaj Retina Institute, LVPI, and let me take you through the case of coach-like response in CRB1 associated rod cone dystrophy. So this is a 45-year-old gentleman hailing from West Bengal who presented to ROPD with complaint of painful blurring of vision in left eye for 3 months. He was diagnosed as right eye primary angle closure and left eye primary angle closure glaucoma and both eye retinitis pigmentosa elsewhere. He was referred to us for further management, and he gave history of nyctalopia since childhood, but no parental history of consanguinity or any addiction or systemic illness, and he reported no family history of similar kind. So he went ahead with ocular examination, and his best corrected visual acuity in the right eye was 20/50. However, the vision didn't improve to 6/6 with age-appropriate near-ad. Left eye had no perception of light. Some PI was noted at 10 o'clock in the right eye and 2 o'clock in the left eye. The IOP measured was 10 millimeter of mercury in both eye. So we went ahead and looked at his fundus. And what we noted was in the right eye, there was disc pallor and 0.6 cupping, attenuated arterioles, pigmented bony spicules, small yellow deposits at mid-periphery. We also noted that inferiorly there was vitreous hemorrhage and retinal telangiectasia with exudation. Sorry, that was not captured in the imaging. Additionally, in the left eye, we noted total glaucomatous optic atrophy, and similar to right eye, in inferotemporal quadrant, there was retinal telangiectasia and exudation. So we went ahead and got autofluorescence done for our patient, where we noted that there was diffuse hypoautofluorescence sparing paraarterial retinal pigment epithelium, and also hypoautofluorescence surrounded by hyperautofluorescent rim at macula, predominantly in the left eye compared to the right eye. So we did a fundus fluorescence angiography for our patient, which revealed that there was capillary non-perfusion and diffuse capillary and focal leakage in the areas of these abnormal vessels. Similar to the light bulb telangiectasia, and these increased in intensity in the later stages. This is a horizontal 9 mm right eye OCT scan of a patient where what we can note is there is altered foveal contour, cystoid macular edema, subretinal fluid, elongation of photoreceptors, and thickening of inner retinal layers nasal to the fovea with outer retinal layer loss, probably indicating abnormal lamination. Similar findings were noted in his left eye OCT. Additionally, there was outer nuclear layer schisis. So we perform an ERG for our patient in Metrovision following ISF standard protocol, which revealed that there was severely reduced scotopic and photopic responses, suggestive of severe form of rod cone dystrophy in both the eyes. So with all the presentation of our patient taken into consideration and multimodal imaging, we concluded a probable diagnosis of right eye primary angle closure, left eye primary angle closure glaucoma, and both eye rod cone dystrophy with codes-like response and cystoid macular edema. So the patient was advised for anti-glaucoma medications. Right eye, he was planned for anti-VEGF followed by laser and cryotherapy, and for genetic testing and counseling with family screening. So the patient underwent 4-step genetic approach. Under pre-test counseling, there is phenotypic and pedigree charting was done. The phenotyping, which we already saw. So we did a 3-generation pedigree charting, which revealed that he was born out of non-consanguineous marriage, and there was no gene pool were not restricted. So no other family members had any known eye disease. On whole exome sequencing, a homozygous missense variant in exon 3 of CRB1 gene that results in amino acid substitution of serine for cystine at codon 266 was detected. So this variant is of autosomal recessive in inheritance, and the ACMG classification as per gene lab was variant being likely pathogenic. Just a small note on CRB1, that is, the variants are the second most common gene mutation found among LCA patients, accounting for 7.4 to 10%. So there has been reporting that 0.5% of the prevalence of IRD related ports like vasculopathy in recent studies. And we did note that there was paraarterial retinal pigment epithelium sparing in our patient also. So according to J.R. Heckenlively, he postulated that there is a permeable factor that is being released by retinal arterioles, which have a positive influence on the RP processes. So thereby temporarily retarding the degeneration locally in the areas of these or adjacent to retinal arteriole. We also noted cystoid macular edema in our patient. So that is this CRB1 transcript CRB1A that has been located in, I think, within Muller's glial cells. So their loss manifesting as irregular number and size of their apical villi. So It has been postulated that Muller cell loss of this integrity may lead to some kind of abnormal fluid transport and macular edema. Few of the other variants where course-like response has been reported. And when we see the different modalities for management of course-like vasculopathy, they include anti-VEGF, that is vascular endothelial growth factor, laser photocoagulation, cryotherapy, dexamethasone implant has been tried, and surgical when there is exudative retinal detachment can be scleral buckle and pars plana vitrectomy mode. Thank you, and I open this case for discussion.
Excellent presentation, Dr. Prithvi, and nicely documented, and especially the way you described everything. Very nice. So now I would like to, invite a comment from Munna ma'am first, and after that maybe followed by Deepika, and Omar can give concluding remarks.
Very nice case, Dr. Prithvi. And I think clinically the paravascular sparing is what is very typical of CRB1. It's also important to look into the periphery. And sometimes we may just do a cryo or a laser. We need not always give an anti-VEGF injection because the exudation may be very localized. And yes, I think doing a gonioscopy is important. A lot of these patients do have glaucoma as well. So yeah, I think probably this is one phenotype where you look at it and you're reasonably certain it's a CRB1 mutation, and also the presence of cystoid macular edema as well. Yeah, I think probably that's all I would have to say.
Yes, Dr. Puna. Yeah. Thank you, Prithvi. Like Dr. Muna said, the autofluorescence is characteristic. When you showed the fundus photo, actually, I was thinking of like in the fundus clinical appearance, the spicules were more of, the pigmentation was more of bony spicules than that clumped pigments, which we see in CRB1. And also, like, it was very difficult to detect clinically. There was that paravascular sparing. It was more evident in the autofluorescence. So I think I have always seen CRB1 so far, like very few cases where I have seen that clump pigments, and clinically as well, we can detect that paravascular sparing. It was very interesting to see that this kind of spicule presentation, which we see in other classic RP, which we call, is also seen in CRB1. That was my point. And the OCT, it showed cystoid macular edema with the subretinal fluid cavity. For so much of degeneration which we are seeing in the periphery, we did not see thickening of the retina also, which we see in CRB1 specific retinopathies. So that was also interesting for me. And I always make sure this point that I was referring to our fellows as well, that when we see cystoid macular edema in any retinal dystrophy cases, always look at the periphery and rule out any other vascular or secondary lesions which can cause this cystoid macular edema than just treating it as degenerative CME at the first go. That's all. Thank you. If anyone has comments on that phenotype, like the the clumps and the OCT findings, that would be helpful. Thank you.
Munna ma'am has raised their hand again.
I used to think about the nummular lesions being typical, but now I've seen a few more which are bone spicules. So yeah, and I agree, probably the thickening was not seen because of the cystoid macular edema. Probably that's why we're not able to pick up the thickening of the inner retina, which is otherwise fairly typical of CRB1.
Also, we were able to differentiate the layers. Actually, the differentiation of the layers was quite good. Even though there was CME, we were able to differentiate the inner retinal layers as we see. Yeah. Thank you.
Sports like vasculopathy, rest of the things were little atypical. I mean, if you at least that's why I think. What's your opinion, Mr. Omar, on this?
So, sorry, are you asking me for now?
Yes, I'm asking you. So basically, we're discussing the pigment pattern on the case which he presented, like typical coin-like tubular pigmentation, and also the poor differentiation of retinal, what we usually get in CRB1 as opposed to this case. I mean, of course, this can happen. So your comments on that?
Yeah, no, great case again. Yeah, I agree that it's classically described to have the nummular pigmentation, but as you're all saying, we see a lot of variation now. We always have the initial classic description, which is very helpful, and then we see all kinds of, what normally happens is the most severe phenotype of any gene is described first, and then as the years go on, we find milder, either we find different presentations or we find milder versions or non-syndromic versions of syndromic genes. So CRB1 even now we have a maculopathy, a macular dystrophy that can be associated with CRB1 when you have that 167 to 169 in-frame deletion. And that's just a maculopathy. And before we'd have thought that's mad to think that that'd be associated with CRB1. So as you say, we don't always get the nummular pigmentation. Sometimes we just get diffuse atrophy or bone spicule-like pigmentation. Similarly, I think with the, classically you get loss of laminations, but sometimes you can differentiate the layers. Maybe just the hyperreflective boundaries look a little bit more thickened than usual, and that's all you see rather than clear loss of lamination in CRB1. And as you say, it's the Coates-like vasculopathy can be really tricky to treat. We see it in other conditions as well, but CRB1 is the classic one where it's described. And if you just have a little bit in the periphery, you could laser it. Sometimes we have these big lesions. It's very hard to know what to do with them. And I think I found for the big lesions, anti-VEGF doesn't really do much, but Ozurdex can help, but it's temporary. So maybe it gives you a bit of drying up and then you can laser or cryo afterwards. But yeah, some of them, they don't move much, but others, they progress very quickly. So it's important to monitor closely and treat early, I think.
So I think one comment is from Dr. Vinod, followed by Parveen ma'am.
Thank you for a very nice case. So one thing I noticed is that in our series, we had one very severe case of Coates-like vasculopathy. This was when we were not doing sequencing, and this patient actually developed a lot of vitreous fibrosis, and actually I had to take up this patient for surgery, but he fortunately did quite well. He's still in follow-up. Second question I wanted to know is, has anybody of you have seen a case of retinitis pigmentosa like picture where you have a capillary hemangioma or capillary hemangioblastoma, what we call, but we similar see in VHL syndromes? So I have those two cases. One I have reported, and I think Dr. Jerry Shields' group have reported one similar case. So I wanted to ask whether it has something to do with CRB1, and again, this was a pre-sequencing era.
Dr. Omar, any experience on that?
Exactly as you say, if you see capillary hemangioma, you have to worry about VHL. So think about that. But you can get these Coates-like vasculopathies or vasoproliferative tumors, even with not just CRB1 but other retinal dystrophies. I had an USH2A patient who had typical RP, but then a really exudative lesion inferiorly. As to whether it's a capillary hemangioma, I don't think I've ever seen myself a typical capillary hemangioma where there's a feeder vessel and everything complicating RP, but obviously you've seen it, and it's certainly, I'm sure it can exist, but certainly the Coates-like vasculopathy can take various forms. It's not really Coates disease, though we call it Coates-like vasculopathy, and you can get things that look like hemangiomas or certainly vasoproliferative tumors, and it is hard to treat.
Thank you.
Parveen ma'am, your quick comment, and Dr. Shubhangi can be ready in the meantime with a case.
Yeah, I just have a couple of comments. Number one, we often think that cystoid macular edema in IRDs is not really exudative or in nature, but in presence of CRB1 and in presence of a peripheral telangiectasia, we automatically believe that here the cystoid macular edema would be probably more exudative. But if I'm Prithvi, you did have a fluorescein angiogram, but I'm not sure whether we saw any leakage there. So would the leakage on FFA still be still hold the same validity in the presence of a peripheral telangiectasia, or we can consider that here it is automatically due to the peripheral telangiectatic process? The second comment, I don't know whether I have not seen glaucoma very often with CRB1, and whether this, if we look at, since you've already done a whole exome, would it be worthwhile looking at the other genes, the whole sequencing, and suppose you could preempt the genetics lab, because they would be searching for the genes associated with retinitis pigmentosa. You may not have marked that additional glaucoma was there. So you probably have a chance of looking at one of the glaucoma causing genes as well. And just a thought.
Right.
So here was angle closure, is that right? Because she had PIs, the patient before. So some of our CRB1 patients are hypermetropic, maybe not all. So I wonder whether here it was simple angle closure, but as you say, maybe there's a genetic cause as well.
Yeah, since we already have the genetic testing with us, I think
Why
if
not
we
look
tell
for-
them that there is a glaucoma associated as well, you may tumble upon some interesting finding there. So, and here also, I don't think the fluoresceint angiogram did show too much of cystic leakage there. So I wonder if still it is the molar cell hypothesis which would be working here, and the patient may not be responsive to anti-VEGF therapy and all those things.
Right.
Thank you. Wonderful case, Prithvi, once again. Thank you for sharing.
Thank you so much. I think we'll move on to the next case, the third case by Dr. Shubhangi Tripathi. She is a fellow at Narayana Nethralaya, Bangalore, and she'll be sharing normal fundus hidden clues revealing CSNB and nyctalopia with retinal signals. Dr. Shubhangi, if you could please share your screen.
Yes, sir. Yes.
Start your video also. Dr. Shakanta, you wanted to make a point in the meantime, if you want to make the point while Dr. Shubhangi is sharing her screen.
Yeah, I just want to make a quick point regarding CRB1. So CRB1 is one kind of gene which the variation occurs prenatally. So most of these earlier stages of CRB1, you see this flat macula. So compared to RPGR, or you can say RP65, where the variation occurs postnatally. So any change, because these gene helps in retinal lamination, and basically CRB1 helps in epicobasal polarity, and it also forms the outer limiting membrane or external limiting membrane. So that is what I wanted to tell everyone, sir. CRB1, you get this abnormal ratio between the inner segment length on OCT compared to outer segment, because there is lamination error. Yeah.
Right. Thank you. Thank you so much for the comment. Dr. Shubhangi, please go ahead.
Yes.
If you could use the slideshow for us and the presenter view for just yourself.
Yes, sir.
Showing the presenter view for all of us, you can use slideshow.
Yeah. Okay, sir. Is it visible now? Is a slideshow?
It's fine now. You can go ahead. It's fine now.
Yes. Good evening, everyone. So I thank Dr. Simar and the entire AIOS team to giving me this opportunity. So today I'll be presenting normal fundus with hidden clues, revealing CSNB and nyctalopia with retinal signals. So the overview here would be, when do we suspect CSNB in a normal looking fundus clinically, and the role of electroretinogram, and eventually narrowing it down to the disease genetic etiology. So before starting with the cases per se, I'll just review the cellular origin of the ERG waves. In the dark adapted 0.01, the B wave is contributed by rod on bipolar cell, and in the dark adapted 3 and 10, the A wave is mainly contributed by the rod photoreceptors, and minimal contribution is by the cone system. For the B wave, it is mainly by the rod on bipolar cells and cone system. And the dark adapted oscillatory potentials, it is by the amacrine cells and the retinal ganglion cells. And the light adapted ERG, the LA flicker, the peak is by cone on and off bipolar cell. And in the light adapted 3 ERG, the A wave is by cone photoreceptors and off bipolar cells. And the B wave is by cone on and off bipolar cells. So coming to the cases. So first case, we had a 23-year-old male with complaints of shaking of eyeball and outward deviation of the eye, which the parents documented when he was around 9 years of age. Upon asking, the patient also complained of low vision at night since childhood. And as we can see here in the pedigree, similar complaints were noted in the elder sister also. Now coming to the visual acuity. So in the right eye, best corrected visual acuity was 6/30 with a refractive correction of -8 diopter sphere and -3.5 diopter cylinder at 15 degrees. And in the left eye, the best corrected visual acuity was 6/24 and 12 with a refractive correction of -5.5 diopter sphere and -4.5 diopter cylinder at 150 degrees. Anterior segment was within normal limits. Upon fundus examination, the blood vessels and the disc looked unremarkable, and there was no arterial attenuation, except for the disc being tilted, suggestive of myopic features. And the FAF was also unremarkable. Only we could see the lattices present. The OCT showed outer and inner retinal layers intact. So we went ahead and did the ERG. Now here, as we can see, in the dark adapted 0.01, the D wave is undetectable, and the dark adapted 3 and 10, the D wave was suppressed, and showed electronegative waveform, where the B by A amplitude ratio was less than 1. Now in the light adapted 3, the A wave was present but of broad, and the B wave was of reduced amplitude, and the LA3 flicker was of subnormal amplitude. So this was suggestive of generalized rod and cone-mediated on bipolar cell dysfunction. Now, in our case, so in our case, we could see the fundus was clinically normal, and in the dark adapted ERG, there was A wave preservation and B wave reduction, which was consistent with the on bipolar pathway dysfunction. Also, as we could see in the pedigree, the elder sister was affected. So this is likely to be autosomal recessive, and so it could be because of TRPM1 gene. Now coming to the case 2. So here we had a 16-year-old male who presented with photophobia and subnormal vision even after refractive correction in both eyes since childhood. In the pedigree, as we can see, the patient's elder brother and the maternal uncle were also affected. Now coming to the clinical examination, the visual acuity in the right eye was 6/7.5 and N6 with a refractive correction of -3 diopter sphere and -1 diopter cylinder at 170 degrees. And in the left eye, it was 6/7.5 N6 with refractive correction of -3 diopter sphere and -1.5 diopter cylinder at 10 degrees. The anterior segment was within normal limits. On clinical examination, the fundus, the disc, and the vessels again looked unremarkable, only with the bite without pressure. The FAF was also unremarkable. The OCT showed outer and inner retinal layers intact. Now coming to the ERG, so here we could see the B wave was reduced. In the dark adapted 0.01, the B wave was reduced but detectable. And the dark adapted 3 and 30 were electronegative again. However, here, as we can see, the light adapted 3 and the light adapted flicker were suppressed, significantly suppressed. So this was suggestive of generalized rod on and cone on plus off bipolar cell dysfunction. So again, as we discussed, clinically, it was a normal looking fundus. In the dark adapted ERG, it was A wave preservation and B wave reduction, again suggestive of on and off bipolar pathway dysfunction. Now here, as we saw elder brother and the maternal uncle were affected. So it is suggestive of X-linked inheritance, probably of CACNA1F gene. So concluding both the cases, when do we suspect a CSNB? When do we suspect CSNB in a normal fundus? So patient might come with high myopia, subnormal vision, nystagmus, photophobia. However, not all patients will present with nyctalopia, as we saw in the second case. So role of ERG here is it is crucial for diagnosis and providing the clues for causative genes when combined with the pattern of inheritance. And comparing complete and incomplete CSNB. So in complete CSNB, majority of the patients will present with nyctalopia, high myopia, and nystagmus. The subnormal vision might or might not be there. And incomplete CSNB, majority will present with photophobia, nystagmus, and subnormal vision. However, nyctalopia might not be the presenting symptom. Now, bipolar cell dysfunction, as we saw, complete CSNB has on bipolar cell dysfunction. However, incomplete has both on and off bipolar cell dysfunction. In the dark adapted 0.01 ERG, in the complete CSNB, it is severely reduced to undetectable. In incomplete, it is reduced, but it is detectable. And in the dark adapted 3 and 10, both will show electronegative ERG. And the light adapted in this complete CSNB, the 3A wave will be near normal, and B wave and LA flicker will be subnormal. However, in incomplete CSNB, as we also saw in the case, it is severely affected.
Thank you, Dr. Shubhangi. If you could just go back to your electrophysiology slide, and just for a quick point of discussion, Dr. Omar already mentioned this in his presentation very nicely. If you could just walk us through the electrophysiology again, Dr. Omar, differentiating complete, incomplete, and the RIGS type, because this is the crux of the presentation here. You have a normal fundus. The patient says night blindness, some reduction in vision in some cases, but relatively good vision. So if you could just walk us quickly through the electrophysiology, the first case and the second case, what we should be looking at and diagnosing, please.
Yeah, sure. Thanks. A great presentation again. And exactly as you say, so this is complete CSNB. It was first described by Yozo Miyake because the DA.01 is completely absent, whereas in incomplete CSNB, it's incompletely absent. That's the reason they were so named. And that was even before the genes. He postulated they'll have different genetic causes, and he was absolutely right. So here you get an electronegative DA3 and DA10 in both kinds, but the LA3 has that particular shape which you showed, that broadened A wave trough, sharply rising but attenuated B wave. Usually the I wave is still present because that's from the off pathway, and you get an attenuated LA3 flicker. But really that shape of the LA3 is so pathognomonic for on bipolar cell dysfunction. It either means they've got complete CSNB or they might have MAR, the LA3 single flash, and then as you were showing the flickers.
Dr. Shubhangi, the LA3 broadened A wave. I think that was a very
that's right. Yes. Yeah. Exactly. So I think that's a really, and like I showed, you can get that even with a handheld ERG and a good recording. You can even see that in 5 minutes, and then you know what the patient has. And as you say, NYX is the commonest, but that's X-linked. And because here there were 2 siblings, a female affected as well, then you think of TRPM1 or GRM6 or LRIT3 or one of these other ones, GPR179. And then this new gene that's about to be published, EGFLAM, can give you that as well. And then for incomplete CSNB, because the defect is presynaptic, it affects both on and off bipolar cells. Cones connect to on and off bipolar cells, whereas rods only connect to on bipolar cells. So the DA.01 is incompletely abolished. That's why it's called incomplete CSNB. So it's reduced but not undetectable. The DA3 is electronegative, and the bright flash also electronegative, like for complete CSNB. And then the LA3 is much more attenuated because both on and off bipolar cells are affected, and the LA3 flicker as well is more attenuated and often shows you a double peak, like you're seeing here in the flicker. There's, instead of being just one peak, there are 2 peaks. It's like a double peak and then another double peak. So that's a clue that it could be incomplete CSNB where you've lost both on and off bipolar cells. And then the commonest genes here are CACNA1F, CACNA1F, which is X-linked. So this was male. And as you showed in the family history, the only thing for this family history may be that the mother and father were put the wrong way around, because it looked like the paternal uncle was affected, but obviously it must be the maternal uncle if it's X-linked. So apart from that, that would go with X-linked inheritance. So CACNA1F is the commonest cause. But if it was autosomal recessive, then CABP4 is another gene associated with incomplete CSNB.
Thank you. Thank you so much, Dr. Omar. And I think we're running short of time. We would stop the discussion here on this one, because this very clear from the electrophysiology what the case speaks for itself. Thank you, Dr. Shubhangi. And I think we can have the next CSNB case by Dr. Priya Prabhu from Shankara Nethralaya, Chennai. So these two were normal fundus, and now we'll have some abnormal looking fundus to see. Dr. Priya, if you can share your
Good
screen.
evening. Sure, my screen is visible, sir.
No, it's not yet. Should I share it on your behalf if there's a problem?
1 second, sir.
So meanwhile, the screen is being, shared. So I've shared the photograph of one of the angioma patients in RP in chat. So if everyone wants to have a look at that. So it is not a very typical angioma.
Looks more like a VPT, sir, what you shared. So it's
Maybe a
solid
VPT.
mass there.
Yeah, but it's not the typical location, and you can see a feeder vessel and a draining venule as well, because all the retina is gone. So it's not that very well dilated and tortuous, but it is this draining supplying artery is definitely more dilated than rest of the arteries.
Yeah, right. Dr. Priya, please go ahead.
Yes, sir. Thank you, sir. Thank you for the introduction, sir. Good evening, everyone. I am Priya Prabhu, Vitreoretinal Fellow from Shankar Nethralaya, and I'm here to present a case of. So the next slide is not moving. Is it visible for you?
Just click once on the screen, please, on your screen.
Yes, sir. Yes,
Yeah.
sir. I'm here to present the case of a 12-year-old boy studying in the 7th standard who was brought by his parents after noticing that the child had a difficulty in the night time for the last 5 years. There was no history of similar complaints in the family members, but there was a history of parental second-degree consanguinity where the maternal uncle had married his niece. On ocular examination, the best corrected visual acuity in both the eyes was 618 N12, and the intraocular pressure and the anterior segment examination was normal in both the eyes. Fundus examination showed discrete white dots present throughout the fundus, radiating from the disc to the periphery, sparing the macula. And the disc had possibly mild pallor, and the macula was normal with a foveal reflex was present, and the vessels had a normal caliber. These were the differential diagnoses which were considered at that point. The patient underwent further investigations, and green fundus autofluorescence showed low background autofluorescence. The red-free images highlights the white discrete dots better, which are also seen to involve the papillomacular bundle. Spectral domain OCT of both the eyes shows RP projections seen towards the outer retina, seen inferior to the fovea in both the eyes, and there is also a little ELM thickening which is noticed in the left eye. And the patient underwent standard ISCEV protocol full-field ERG, and dark adaptation showed an almost flat B wave, which is seen on single flash ERG, and it showed a reduced A and B wave amplitude, which was noticed on DA 3.0 ERG, and DA 10 ERG was not available in the machine at that time. And the light adaptation showed normal responses in both the eyes. On prolonged dark adaptation for 6 hours, we see that the A and B wave amplitudes are significantly increased to almost normal in both the eyes. and hence a diagnosis of congenital stationary night blindness with fundus albipunctatus was made. And it was confirmed with NGS targeted resequencing of 14 candidate genes for CSNB, which was positive for RDH5 mutation, likely pathogenic variant. And the parents were found to be carriers on segregation analysis. It was an autosomal recessive inheritance, and there was mutation in the protein G238A. CSNB can present with a normal or an abnormal fundus. The normal fundus is further classified into Riggs and Schubert-Bonstein type, which is further classified into complete and incomplete CSNB, which was discussed earlier. Abnormal fundus can be present in fundus albipunctatus and Oguchi disease, which can have the characteristic fundus findings. The image here shows the genes which are involved in CSNB, which are present in the bipolar cells, in the rods, and in the RPE. The gene RDH5, which is present in the RP, is which encodes the gene which encodes the enzyme dehydrogenase, helps in the conversion of 11-cis-retinol to 11-cis-retinal, and this is being affected in fundus albipunctatus. And these accumulated retinal esters are what we see clinically as a yellow or white dots present throughout the fundus, and they typically spar the macula. These patients present with a night vision, light blindness present since childhood, or they may even have a dark adaptation delay, and they may even be asymptomatic. On OCT, there are RP projections seen towards the outer retina corresponding to the white dots. There may be a low background autofluorescence, and the ERG shows severely affected scotopic responses, which show complete reversal to almost normal following a prolonged dark adaptation for about 4 to 6 hours. And the cone responses are normal in most of the patients, and however, they may also be reduced responses noted in older patients. And the adaptive optics SLO image, images B and D of a healthy subject here show a regular cone photoreceptor mosaic and cone photoreceptor density compared to the images A and C, which are seen in a patient with fundus albipunctatus, showing an irregular cone photoreceptor mosaic, and it also shows a reduced density of the cone photoreceptors. So the differentials, benign flecked retina, they present with normal vision, and they have a normal ERG, and they have the hyper autofluorescent flecks, and they are incidentally noticed on routine fundus examination. The other differentials, retinitis punctata albicans and Leber's congenital amaurosis, they have a low visual acuity, which progressively deteriorates over time with reduction in the visual fields. And on examination, they have a waxy disc pallor with arteriolar attenuation. And with time, they also have bony spicules with pigmentation and RP atrophic changes. And ERG doesn't show reversal following a prolonged dark adaptation. And patients with fundus flavimaculatus, they have a characteristic yellowish white pisiform flecks, which are hyper autofluorescent with or without macular atrophy, and the ERG findings are variable. So this case emphasizes the importance of full field ERG with prolonged dark adaptation in a patient who walks in with night blindness and has white flecks on fundus examination. I would like to thank my HOD, Muna Bende Ma'am, Shankar Netralaya, and AIOS for giving me this opportunity. Thank you, one and all.
Thank you. Pierre, it was a nice presentation. So, I mean, most of the time, the fundus albipunctatus gets confused with venous fleck retina, but you can differentiate other LCA and fundus punctata albicans. You can just differentiate based on just OCT itself.
Yes.
So LCA and OCT punctata albicans will have characteristic photoreceptor loss, and autofluorescence will also have a typical pattern. And if you look at the flex deposits in the benign fleck retina and fundus, they are also clinically a little different. They don't look the same. Fundus albicans will be more finer and things like that. Dr. Omar, any comments by you, and followed by Parveen ma'am. I know it's a favorite topic, CSNB.
Thanks. Yeah, great presentation. And as you say, often you get in these visual cycle disorders, you get these subretinal deposits. Similarly, in vitamin A deficiency, you get them in the same place in the retina. Even RP65, LRAP, those ones that give you degeneration, but they still involve the visual cycle, same place, subretinal deposit. So it's very interesting that they all give you that phenotype and a low autofluorescence, as you showed. We do have some patients with RDH5 who do get some degeneration, some get macular atrophy, although most of them are stable. So you kind of positive about most of them, but we have had some people with degeneration. We published a paper with someone called Simon Peterson Jones, who has many animal models of disease. And for some reason, his cat models of RDH5, they all have macular atrophy, interestingly, but only some of our patients. And I guess one other thing to think about is Bothnia dystrophy, RLBP1, because that's progressive. So as you say, it's good to do the genetics because RDH5, much more favorable prognosis from RLBP1, although they can initially look very similar. But yeah, great case. Thank you.
Yes.
Yeah, I agree with Dr. Omar. Thank you. That I still believe the genetic testing is important because sometimes, especially in the early stages, when the children come to you, high myopia and the vision not improving, and they are still in their teens, at that point of time, it is very difficult to label them congenital stationary night blindness without having a genetic test, which is confirmatory. And some of the even the complete CSNB, especially if it is caused by GRM6, I have noticed that their amplitudes can be much lesser as compared to the TRPM1 gene, and especially the photopic ones as well. Those are the specific cases where I feel if I do a long duration extended protocol, it becomes much more easy to differentiate whether it's the only on bipolar pathway which is getting affected, especially when the amplitudes are less reduced in the photopic responses. Then sometimes to clearly distinguish that typical pattern of the B wave, the bifid and widened pattern, sometimes may become more challenging. And in that case scenario, I go to my extended protocols, and they clearly show me that whether it is the on pathway alone which is affected, or it is both on and off pathway. So otherwise, a great case. And yes, some of the these RDH5 are known to be progressive as well. So we need to keep that in mind when we prognosticate these cases.
Yes.
So much, ma'am. I think one last comment from Shrikant. Meanwhile, Dr. Smile can start sharing the screen.
I have a quick comment and question for Omar. So I have come across a similar case last week. So fortunately or unfortunately, both RLBP1 and RDH5 gene testing that came positive. But what was interesting that I didn't do for 6 hours of patching. I did for 2 hours. But I could see some amount of rise in the scotopic phase. So what's the ideal, how you perform such dark adaptation, prolong, what's the cutoff time for delayed dark adaptation or prolonged dark adaptation?
Yeah, thanks. I think different places do different amounts of dark adaptation, and it's kind of what's practically feasible. So I've seen some places where they just patch for several hours. What we tend to do at Moorfields, the department at Moorfields often post the patient an eye patch with some instructions how to do it, and they say please keep it on for 12 hours. So when the night before when you go to sleep, tape this patch over your eye and then keep it on until you come to the department. And they just do it in one eye so they can still see to walk around and come to the department. And then they set them up in very dimly lit conditions so that they don't light adapt them. And then they start with the dark adapted responses, maybe even go straight to the bright flash just so that you can see if the A waves recovered or not. But they tend to do overnight dark adaptation. But I guess it depends what sort of situation you have.
So much. Now I'd like to invite Dr. Smile. She's a junior resident at RP Center, New Delhi. So please, over to you, Dr. Smile. You can start your presentation.
Introduction, sir. Myself, Dr. Smile. I am resident at RP Center, East New Delhi. I am presenting a case titled From Carrier to Patient, Choroideremia in a Female. So we had one 44-year-old female who presented to us with gradual onset, progressive diminution of vision in the right eye for 2 years, associated with myopia, not associated with any other complaints. There were no systemic features. On probing the family history, she told that her father had severe vision loss in the 6th decade of his life, cause of which was undiagnosed. He underwent both eyes cataract surgery at 50 years of age, leading to no improvement in vision. There was no history of any consanguinity. On ocular examination, best corrected vision in the right eye was 6/18, in the left eye 6/9. Rest anterior segment was within normal limits. On fundus clinical picture, there were areas of chorioretinal degeneration, diffuse atrophy of retinal pigment epithelium and choroid, and some mid-peripheral pigmentary changes. On fundus autofluorescence, there were areas of hypoautofluorescence corresponding to atrophy of retinal pigment epithelium and choroid. On optical coherence tomography, there were thinning of inner retinal layers, atrophy of retinal pigment epithelium and photoreceptor layers, and increased signal transmission into the choroid. So by all the findings, we made some differentials of retinitis pigmentosa and gyrate atrophy. To confirm our diagnosis, we sent the patient for genetic analysis by whole exome sequencing. To our surprise, it came out to be CHM gene mutation located on intron 10, heterozygous, confirming diagnosis of choroideremia, inheritance being X-linked. Since she was female, so we were not thinking of choroideremia in this patient. Since choroideremia is X-linked, so we screened the son. She has 11-year-old son who is currently asymptomatic with no visual complaints. Visual acuity in the both eyes were 6/6. On fundus clinical picture, there were some areas of chorioretinal degeneration and atrophy and diffuse areas of atrophy of retinal pigment epithelium and choroid. On fundus autofluorescence, there were areas of hypoautofluorescence corresponding to atrophy of retinal pigment epithelium and choroid. On optical coherence tomography, there were sashes at the inner nuclear layers, and at the periphery, there were disruption at the EZ. On reviewing literature, some literature mentioned that choroideremia carriers can also exhibit severe retinal phenotype. One possible explanation is leonization, leading to one of the X chromosome inactivation. So by compiling the clinical features fundus finding, we were suspecting some inherited retinal disease like retinitis pigmentosa or gyrate atrophy, but whole exome sequencing showed mutation in CHM gene, confirming diagnosis of choroideremia. On screening, her asymptomatic son, his fundus and imaging findings also showed signs of choroideremia. So what is choroideremia? X-linked choroideremia is a chorioretinal atrophy characterized by diffuse progressive degeneration of retinal pigment epithelium, photoreceptors, and choriocapillaries. Its prevalence is about 1 in 50,000 to 1 lakh people. It's an X-linked disorder caused due to loss of function mutation in the CHM gene, which encodes Reb escort protein 1. Nyctalopia is often the presenting symptom. There will be preservation of central vision until later in the disease. Initial fundus appearance shows fine peppery-like RP mottling at mid-peripheral retina. Later on, there will be atrophy of inner choroid and exposure of Beard's sclera. OCT will show disruption of RP and thinning, and finally leading to diffuse chorioretinal atrophy. Fundus autofluorescence shows hypoautofluorescence of the impaired RP. Diagnosis is confirmed by genetic testing, which shows CHM gene mutation. This case underscores that female carriers of CHM mutations can manifest symptomatic disease. So early fundus changes in an asymptomatic son calls for routine screening, enabling early diagnosis, genetic counseling, and making them potential candidate for gene therapy or any upcoming therapeutic interventions. I would like to thank Professor Vinod Kumar sir and AIOS for the opportunity. Thank you.
Thank
I'm
you so
open
much.
for discussion.
Lovely case, Dr. Vinod sir. Just quick comment from Dr. Omar. So CHM carriers, what signs we should be looking at, and features in choroidemia carriers.
Yeah, thanks. Great case. Yeah, so often they have a pigmentary change in the fundus that's a bit irregular, not like the regular mud splattered fundus you get in ocular albinism carriers where you have kind of lines of radial pigmentation. Often it's kind of a bit more messy, but all at the level of the RP, usually not with much degeneration. But as you showed here, because of its random X inactivation, you could have an unlucky female where the good X chromosome was inactivated in most of the cells, and unfortunately they can get, they never seem to be as severe as the males, thankfully, but we have got a few females who are similarly severe where they almost as severe as the males because the good X got inactivated. The other things you'd think of choroideremia definitely as you did. There's a dominant RP65 codon 477 mutation that can look like that, autosomal dominant. Although rhodopsin is usually associated with dominant RP, there's a particular MET216 lysine that can also look like that. So there are some dominant diseases that can look like that, but choroideremia is much commoner. Purna knows it because he's got another case with a similar, a nearby codon mutation, and we're in the process of trying to write that up at the moment.
And would carriers normally be symptomatic even if they have those pigmentary changes, or mostly?
Yeah, it's variable. So we have found that later in life, even the mild ones can get symptomatic. They mention a little bit of night blindness. The ERGs are slightly reduced or not affected, or the whole spectrum of disease. And as in this case, they could be a lot more severe.
Right. Thank you, Dr. Omar. And I think we are running short of time. We would go to the last case now. That is by
comment. Vinod wants to comment. I think if this is case.
Dr. Vinod, please. In the meantime, Dr. Shreya and Grish, if you could start sharing your screen from Narayana Netralaya, Bangalore.
Actually, I really wanted to ask a question from Dr. Omar. So we recently had a patient who had RPGR confirmed mutation, and she was active. So again, we could have thought of lionization, but is it possible that if she has 3 daughters affected as well, so is it possible that all 3 daughters affected would have lionization as well?
Yeah, I think it is possible. It's each daughter would have a 50-50 chance of getting the RPGR X from her, and then they can have again. Although we say it's random, they're probably, as you might be alluding to, that there may be something. We think there are hereditary things as to which X gets inactivated. We know some females have skewed X inactivation, and there seem to be other genes that contribute to whether you inactivate this X or that, though we think it's random 50-50. Often it isn't. And so maybe that family also has a tendency to skewed inactivation, which unfortunately for those daughters, skewed to inactivate the good X. That could be one possibility. Often we kind of see the more severe stuff, like we see recessive cases where there's more than 1 in 4 siblings affected. So that's unusual. It's probably because there are lots of other families where we're not even seeing the 0 patients affected where the parents are carriers. So similarly, there's probably lots of X-linked RPGR out there where we don't even see the carriers at all because they're so mild, and then we're skewed. We'll see some families where you have a few females more severely affected than expected, but maybe it's something else hereditary that determines which X gets inactivated. Yeah, but very interesting.
Thank you.
Right. Dr. Shreya, please go ahead.
Yes, sir. So first of all, I'd like to thank AIOS for this wonderful opportunity. Blinded by the Night, Unveiling Vitamin A Deficiency with ERG Insights. Good evening all, this is Dr. Shreya, and today we'll be discussing 2 very interesting cases. So let's look at case 1. A 46-year-old gentleman comes to us with complaint of nighttime vision difficulty since 1 year. He was a chronic alcoholic, known case of alcoholic liver disease, history of hepatic encephalopathy, but no family history of night blindness, and on general physical examination, there was loss of buccal pad of fat. Ocular examination, both eyes' best corrected visual acuity was 6/18 with decreased contrast sensitivity, anomalous color vision, and nuclear sclerosis grade 1 cataract. When we looked at the fundus, both eyes showed RP changes along with altered foveal reflex, and fundus autofluorescence imaging and OCT showed intact retinal layers with focal RP and EZ changes in the left eye. So we
went ahead and did full field ERG. Now, both eyes full field ERG showed extinguished dark adapted 0.01 ERG along with reduced A and B wave amplitudes in dark adapted 3 and dark adapted 10 ERG. The oscillative potentials were also reduced, and light adapted 3 ERG was relatively better, but it was still reduced. So we suspected vitamin A deficiency and we went ahead and evaluated vitamin A levels. And we were right. Serum vitamin A levels were low at 0.02 milligram per ml, with normal reference being 0.3 to 0.6. So patient was started on vitamin A supplementation treatment and serial ERG monitoring was done, and ERG was taken at 1 week, 1 month and 6 months post-treatment. So within 1 week of treatment, as we can see here, restoration of rod and generalized cone function was significant within 1 week of treatment. And post 1 month, almost complete recovery was seen in both eyes' ERG waveforms. So if we look at the serial ERG monitoring, at presentation, decreased photopic and scotopic responses. Within 1 week, we start to see recovery, and 1 month complete recovery was seen. Now coming to the second case. This was a 26-year-old young man this time, and he had complaints of night vision problems since 6 months. The fundus looked pretty normal. OCT retinal layers were intact with slightly broadened foveal reflexes. When we did the full field ERG, our findings were similar as seen in case 1 with decreased photopic and scotopic responses, and oscillatory potentials were also significantly reduced. So again, we suspected vitamin A deficiency and we evaluated serum vitamin A levels and they were low at 0.02. So now, as opposed to the previous case where the patient had hepatic encephalopathy and hepatic insufficiency, the cause for vitamin A deficiency was pretty clear. But this was a young man, so cause of vitamin A deficiency was not clear. Hence, we went ahead with a systemic evaluation. On general physical examination, he looked malnourished. When asked leading questions, he had complaints of dyspepsia and frequent loose stools. So along with the gastroenterologist, he underwent extensive workup to identify the cause for this malabsorption, and even intestinal biopsy was done, and the features were suggestive of lipofuscinosis of the intestine, which is the end stage of the inflammatory bowel disease. After finding the cause, again vitamin A supplementation treatment was done and ERG was repeated at 1 week, 1 month and 6 months post-treatment. So if we look at the serial ERG monitoring, at presentation, rod system severely reduced and photopic responses are also reduced. 1 week, we start to see the recovery of the waveforms. 1 month, there is complete recovery, and 6 months, there is sustained recovery of the ERG. So if we see vitamin A, it's a fat-soluble vitamin, the deficiency of which can lead to impaired vision, immunity, and growth. If we look at the causes, it can be varied, from inadequate dietary intake to malabsorption disorders as seen in case 2 to hepatic insufficiency as seen in case 1. And clinical features vary on a spectrum starting from night blindness, xerophthalmia, bitot spots, can progress up to keratomalacia. Fundus findings, we can see presence of humura spots, and in children, we can even see growth retardation. So our diagnosis should be based on clinical suspicion along with ERG and supplemented with serum retinol levels. Just a quick literature review. So Schloll et al. Stated that in vitamin A deficiency, rod involvement is seen earlier and it's more extensive than cone dysfunctions. Perlman et al. Whereas found out that cone ERG in such patients showed delayed latency. And following vitamin A supplementation, Kemp et al. Reported the order of recovery of photoreceptors to be firstly cone function, followed by peripheral rods, and then perifoveal rods function. In the case report study, Beckbain et al., as we can see, so basically effects of vitamin A deficiency on retinal function was studied in 3 patients with different systemic conditions. The initial presentation included characteristic absence of rod function, delayed and reduced amplitude cone ERGs, loss of S-cone function, and subnormal macular function. And after giving intramuscular vitamin A injections, restoration of rod and generalized cone function was rapid, and near normal recovery was seen as early as within 3 days of vitamin A treatment. So serial ERG monitoring gives us the evidence of rate of electrophysiological and functional recovery. If there is no improvement within first week of our treatment, then we need to reevaluate the cause. And rapid recovery of electrophysiological parameters indicates early detection and appropriate treatment. So points to remember from this is vitamin A deficiency ERG shows characteristic rod system predominant dysfunction. Recovery follows a predictable timeline. ERG is superior to serum vitamin A levels for monitoring. An early diagnosis is crucial for complete recovery. And the pattern is significantly different from the hereditary causes. And cause of vitamin A deficiency needs to be worked up and treated accordingly. So it's a treatable condition basically, and a simple problem of night vision actually needs to be evaluated properly. Early diagnosis and proper treatment is there because it could be indicating an underlying, even a life-threatening condition. Thank you.
Thank you so much, Dr. Shreya. It's a nice presentation. Because this night vision problem, I mean, most of the things we couldn't treat earlier, the previous cases earlier year, we could treat and give some results. So that's extremely important, especially in Indian context. Most of the time, especially the liver disease, they may not always present with the icterus and loss of focal pad and all that. It could be very subtle. So you need to have a strong suspicion, and the way we supplement also it's different. I mean, in some of the cases where there's non-malabsorption related vitamin A deficiency, even if you give oral vitamin A, the 25,000 international units tablets BD for 1 month, it does the same job. But when there is a suspicion of, the intestinal disease, better to go for an intramuscular thing, what the way we did in our cases. So, Professor Omar, I mean, everything is okay except for the Professor Omar's recent paper, which we didn't look into. Maybe your opinion and comments on this.
Thanks. Great presentation again. Absolutely. And I'd say also it's important to then think of other vitamin deficiencies. If someone's got cirrhosis and they're not absorbing fat soluble vitamins, and it's the A, D, E case, you might check vitamin E and K as well. If alcoholic cirrhosis, they may be deficient in other vitamins like B12 and folate, so it's worth checking those as well. And I think whenever there's a clinical suspicion, it's worth checking the vitamin A. Although I love ERGs, I would say it's not always necessary, because if there is some clinical suspicion, then just do the vitamin A. Sometimes in our in our setting, people delay it to get the ERGs. The ERGs take several months when actually you could have clinically suspected it and got the result within a couple of weeks. So I would recommend any patient with recent onset night blindness where there's no clear, they haven't obviously got a retinal dystrophy, then it's worth checking vitamin A. And then one of your cases was quite interesting. The second case showed that the DA10 ERG can look negative. The A wave is reduced and the B wave is reduced, but the B wave is reduced more than the A wave, and people misinterpret that as inner retinal dysfunction. But the clue is because the A wave is reduced, it tells you the problems with rod phototransduction, and the only reason you're seeing an ERG that looks negative is that the cone system response in the dark to a bright flash in some people has that waveform. It's just we never see it because the rod response is in the way. So it's an important way of interpreting when the A wave is reduced, it's rod phototransduction. Even if it looks negative, it doesn't mean there's necessarily inner retinal dysfunction. But yeah, great case. And yeah, do look at our recent paper where we showed why the rods are affected more than the cones. It's basically because when the rods are deficient of retinal, but free opsin activates the phototransduction cascade and desensitizes the rod, whereas in cones they can have a lot of free opsin that doesn't desensitize the cascade. And we showed that a vitamin A deficiency is like having a background on. You get the same kind of ERG effect. But anyway, have a look at that paper and you might find it interesting. But yeah, great case. Thank you very much.
So much. Any other comments from Dr. Simar? I know you work in an institute, medical college setup. Do you get to see a lot of, vitamin A deficiency night vision problems?
Yeah, we do, and especially children mostly do not report it. Adults we do see very commonly, but yes, they respond very well to. It's just need to identify that and look for the cause, and supplementation works very well if you treat the cause. So it's one of the very treatable causes of night blindness. Shrikanta, you want to make a point?
Yeah, I want to add a couple of points. Like few cases of vitamin A that I have come across. So I could see these yellowish white deposits, granular deposits, just like plaque in the mid periphery or peripheral region. And what I've observed that like in RDS5 or RLBP1, where the autofluorescence is nearly normal. So also in vitamin A deficiency, if you perform autofluorescence, it's like you can say photographer's mercy. Sometimes you'll say that, yes, I can see these yellow spots or white spots and the autofluorescence is completely normal. So that is one finding that I have noted. Omar, I have a question. Like, do you note this photopic hill phenomenon in cases of vitamin A deficiency? So so do you increase the even the strength, plus strength to get some response? Like, is there any protocol that you follow?
Not necessarily changing the ERGs we do, but I think the reason it does look electronegative or negative in some of those bright flash responses is because what you're seeing is the photopic hill phenomenon. So the photopic hill is when you have a bright flash, the cone system, when you get over a certain intensity, the B wave starts reducing again, and we never normally go that bright, but a bright flash in the dark, I think the dark adapted cone system has different properties from the light adapted cone system. So what you're seeing in that second patient, not every patient, the first patient didn't show it, but the second one did, that negative waveform is just the cone system response in the dark. So last year we published a paper where we tried to mimic what does the cone system do in the dark with just a dim blue background, just enough to saturate the rods so that you're getting only a cone system response, but not the light adapted one you get with the ISO standard, a kind of dark adapted cone system response. And we looked at that in about 200 adult twins, they happen to be, and about 25% had a negative looking ERG. So that's just a normal dark adapted cone system response in some people to a bright flash, because you're on the other side of the photopic hill, you see a smaller B wave than the A wave. Yeah.
And this one, Shrikant, as he rightly mentioned initially, the serum vitamin A retinol level also becomes very crucial in these cases. And also, if you look at the Scotopac 0.0, and most of the Almec series have like almost like a straight line, flat line. So not like, incomplete, complete. There will be some waveforms. It's not a straight, it's little different, 0.0. So that's something considered. I think if you combine with other like serum vitamin, retinol level and all that, you're almost there. So Deepika, wanted to comment?
No, nothing for this
Dr.
case,
Omar, if I could-
Dr. Puna. Like for the
Go ahead, Deepika.
yeah, I was trying to add point related to the previous, like what we saw the choroideremia. Like it is also often seen in other X-linked genes, so it is very important for us to have a DD of females being RP1, PRPS1. It is known that the females will get affected. Asymmetry is one clue in the X-linked disorders. Also, females get affected probably 1 or 2 decades later than the males. Males get affected early and the females get affected late. So the family history, the clue of females getting affected at a later date, asymmetric nature should also point towards X-linked inheritances. Thank you.
Right. Dr. Umar, I think one scenario that we missed out on this is CAR-MAR. You talked a bit about it in your presentation. So if you could give us some clues in the electrophysiology that we are looking at which should make us suspect that this might be a patient of CAR or MAR and go towards further testing in that regard.
Yeah, thanks. So MAR is a bit simpler because they have the stereotyped ERG findings, whereas CAR can be very variable. So in MAR, often they have recent onset night blindness. They may have photopsia, and they develop antibodies to TRPM1, which is the same protein whose gene is mutated in complete CSNB. And that's why you get identical ERGs often to complete CSNB. So you have complete loss of the dim flash B wave, electronegative bright flash, dark adapted bright flash. Then you have that broad A wave and sharply rising B wave in the LA3. So that can give you a clue to MAR. Obviously, you may have a history of melanoma, but you may have, as we've had cases where they didn't know they had a melanoma, the ERGs pointed us to that. Then we did a whole body PET scan and we found the melanoma. With CAR, and then also rarely CAR can look like that, but it can also, you get different antibodies, some of them undefined, so you can get A wave reduction. So whenever you're suspecting an autoimmune retinopathy, when maybe the functional changes seem to be out of proportion to what you can see on the fundus, and it's not long-standing, there may be some symptoms of weight loss or something like, you think of autoimmune, and then a subset of autoimmune is paraneoplastic, so you may then have to go for a PET scan. But yeah, if you see complete CSNB ERGs and the patient's got a recent history, then you really have to think about MAR. In fact, Neil Bressler was telling me that when they first saw MAR, Elliot Burson, who was an IRD specialist at that time, said, no, these patients have got complete CSNB because the ERGs just look like that. But obviously the history was recent, and then they realized it was the patient had a melanoma.
Dr. Munama.
In our populations, I think it's a question of digging for the history, which people may not tell you because they think it's not important. So
Yeah.
I think since we are looking at a wider audience, I think, you have to keep digging if something is not quite right, and you never know what you'll find at the end of it.
Yeah, absolutely right, ma'am. I think we had a very wholesome.
Simar, I think there are some questions in YouTube. So,
Yeah, please.
So somebody has asked, what are the things to be taken into consideration while looking for a life partner? I mean, in genetics and CSS. And the follow-up question is, if by chance a patient with RP gets married to another RP patient, what are the chances of children having RP? So I think you can just preview. You all know the answer. I think someone can just brief and answer this. Dr. Omar.
Yeah, it's a good. I mean, someone with RP marrying someone else with RP, it depends what the genetic cause is. If they both have recessive RP but different genes, then they could well be fine. But yeah, it is something we advise that when we see a recessive disease, we say that the chances of a child being affected are very low unless you were to marry or partner up with someone whom you're related to. So in the case of recessive disease, then consanguinity obviously increases the risk. But if someone just has RP, undefined, and someone unrelated has RP, they may well have different genetic causes. So in that situation, it'd be good to know, but you may be all right.
One more follow-up question. If one of the couple is having RP, at what age to examine the children is the second question. So
yeah, and I guess as you say, it depends what the RP. If it's dominant RP, then where you're thinking the children may be affected, then you might examine them early. If it's recessive, confirmed recessive, and there's no consanguinity, then I would just advise that it's very unlikely the children are going to be affected. So don't worry. Usually, even with dominant disease, people are always asking us when we say, give your child routine care, take them to an optometrist. But if you're worried, then we're very happy to see them. But because unfortunately for the vast majority of these diseases, we don't have a treatment. So if we picked something up early, what are we going to do? So unless it's something that's going to affect them in childhood, then they might want to know early, might affect their schooling or something, then it'd be worth it. But if it's something that's going to affect them later on in adulthood, maybe a child wouldn't want to know later as an adult. So maybe we wouldn't necessarily do anything early on.
One last question. Is there any difference between parents and children as far as male and female sex is concerned? Basically, X-linked and dominant.
Yeah, it's actually an interesting question. So yeah, X-linked disease, obviously, as we all know, a father can't pass it on to a son because he can't pass his X on, but a mother can. So it's always inherited from a son from their mother, but a daughter can be a carrier. In fact, a father who's affected, their daughter will be an obligate carrier. So that applies to X-linked disease. For autosomal disease, non-X-linked, we think that the sexes are equally affected. But very recently, we've noticed that for some autosomal macular dystrophies and some autosomal RP genes, we get an imbalance. So there's this is why I was saying before that, modifiers, it's the next frontier, like we were saying with the CRKL. And it seems that sex is a modifier in some diseases. Males get more severe, or in others, females more severe, in others, they're equal. And we don't know what, is it behavioral? Is it to do with estrogen receptors in the retina or what? But that's a really important area of research. But that's kind of small print. As you said, it mainly applies to X-linked disease. The male and mitochondrial disease. A father can't pass on mitochondrial disease, but a mother can.
Thank you so much. Over to you, Simar. I think we'll have to call sir and conclude.
I think we have Dr. Santosh still with us. Sir, would you like to take over? I don't think we have a response. Anyway, thank you, Dr. Omar and all the panelists, Dr. Muna ma'am, Dr. Praveen Sain, Dr. Vinod Agarwal, Dr. Shrikant, Dr. Deepika, the presenters, great presentations, and Dr. Poorna, my co-moderator for the excellent moderation. And I think we had a good discussion on all aspects of night blindness, and I think the insights that Dr. Omar brought into, they were spectacular. I think just kind of learning this topic again. Thank you so much.
Thanks very much. It was a pleasure. Thanks for the great discussion.
Thanks so much.
Thank
Have a
you.
good night.
Thank you, everyone. Thank you.
Thank you. Good night.
Good night.
Good night.
Thank you. Good
Thank
night.
you. Good night. Bye-bye.
Good night.